Welcome you all to our today's weekly regular session. We have been doing it for more than a year, that how should I treat my patients following evidence-based medicine. Today we're going to discuss about the non-surgical management of hepatocellular carcinoma. And our today's faculty, local faculty, is Dr. Armand Chaudhary, who is now working as a consultant radiation oncologist in Evercare Hospital. He is a fellow from our College of Physician and Medicine, and also he is a UICC fellow. He has done his fellowship from Tata Memorial Hospital, and he's one of the most bright oncologists now offering treatment to our cancer patient in our country. Our overseas guest faculty is Dr. Vinit Talwar, who is the Director of Department of Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi. He is a good friend of Oncology Club and now a common face to everybody. And thanks to Dr. Talwar for joining us and sacrificing our holiday. Our patron and inspiration, our president, Professor M.A. Heiser, who is always with us, and his presence is the main inspiration for continuing this journey. We are fortunate to have such a leader. As per our culture, I would like to request our president, Professor M.A. Heiser, to formally start the session.
Thank you, Kamal. Bismillahirrahmanirrahim. My heartiest welcome to all of you, particularly to Vinit Talwar and Manager Chaudhary and all the participants who have shared their time to listen to our discussions. Without any delay, I think we should start immediately, or we'll delay by 8 minutes. So Kamal, start.
Thank you, sir. So now I'd like to request our today's presenter, Dr. Armand Chaudhary, who is the consultant in the Evercare Hospital, who will start his presentation. Over to you, Armand.
Thank you, Dr. F.M. Kamaluddin, sir, for your kind introduction. Is my slides visible and I'm audible?
Yes, fine.
Okay, thank you.
Go to the slide show, please.
Yeah. So I should thank our President of Oncology Club, Professor Dr. M.A. Heiser, for being with us. And I should also thank Professor Dr. Vinit Talwar, the Senior Consultant of Medical Oncology from India, to be our guest faculty today. So my today's presentation is on non-surgical management of hepatocellular carcinoma. So this is the outline of my presentation. I will discuss about the diagnosis of hepatocellular carcinoma along with the diagnostic algorithm. Then I will discuss about when we should do the biopsy, the CHILD-PUGH scoring, the BCLC cancer staging, as well as the treatment recommendations in different stages of hepatocellular carcinoma. So here you can see this is the only tumor of the body or only cancer of the body that can be diagnosed radiologically in the absence of biopsy. But definitely there must be some prerequisite like underlying cirrhosis, more than 1 centimeter lesion size, and showing typical radiological feature. What are the features? In case of arterial phase, there will be hyper enhancement, that is called arterial phase hyper enhancement. And in case of venous phase, there will be a portal venous washout. You can see in the image that this is the arterial phase hyper enhancement.
Muted. Please check.
Sorry, sir.
Yeah, please continue. Okay.
And this is the portal venous washout. And like breast cancer, by RADS classification, there is also LIRADS classifications of liver cancer, through which we can categorize liver cancer from liver tumor from the benign to malignant hepatocellular carcinoma. And this is the diagnostic algorithm. And actually it is a guideline from EASL, that is European Association of Study of Liver Cancer, that if any mass or nodule is found in the imaging, then we have to understand that it is less than 1 centimeter or more than 1 centimeter. If it is less than 1 centimeter, then the repeat ultrasound should be done after 4 months. And if it is stable, then again repeat ultrasound after 4 months. But if the size increases, then we have to do the imaging. And what are the imaging? Multiphasic contrast enhanced CT or multiphasic contrast enhanced MRI should be done. And if we found any positive feature, I have already mentioned the feature, that is arterial phase hyperenhancements or venous washout, portal vein washout. So if we found any positive findings, then it is hepatocellular carcinoma. And if we not found, then another imaging study should be done. Like if previously done CT scan, then MRI should be done, or if previously MRI, then CT scan should be done. And if we get any positive findings, that is hepatocellular carcinoma. And but if we don't get any positive findings after the second imaging test, then we have go for biopsy. And when do we need for biopsy? There are different organization have different thought regarding the needed of biopsy in case of hepatocellular carcinoma. And like American Association for Study of Liver Disease, they are based on Leiter's classification. LR4 and LRM should be done biopsy. And Asia Pacific Association for the liver study of liver, they are telling that if the lesion is more than 1 centimeter, then we have to do the biopsy. And EASL have different thought. So the diagnostic and pathological or molecular biology. Regarding diagnosis, I have already mentioned diagnosis requires identification by multiphasic contrast enhanced CT or MRI of typical vascular hallmarks. And in case of more than 1 centimeter size of hepatic lesion. Multiphasic MRI is more sensitive than multiphase detector CT scan. And MRI with diffusion weighted imaging and hepatobiliary contrast agents may identify the high risk nodules. And regarding diagnosis by pathology, histopathological diagnosis of tumor biopsies relies on H&E staining and may be supplemented by immunohistochemistry, which is also recommended in case of unclear cases. And this is the CHILD-PUGH classification. It is why it is necessary, because when we will do the BCLC staging, that is Barcelona cancer staging of liver cancer, then this CHILD-PUGH scoring system is mandatory to define the stage of the liver cancer. So we have to know the CHILD-PUGH scoring system, and we have to know how to do this. I am not going through details of this. And another very important thing is needed, that is the ECOG performance status. That is also mandatory for staging of the BCLC staging, that is the liver cancer staging. And with this ECOG performance status, this is the cartoon for ECOG performance status. Now, the staging and risk assessment. Staging should be conducted according to the BCLC staging system, which includes the extent of the tumor, alpha-fetoprotein level, liver function status, portal pressure, and clinical performance status. And contrast enhanced MRI or helical CT scan are recommended to evaluate the extent of the disease. And it should be remembered that PET CT scan is not recommended to see the extent of the disease. Liver function is assessed by CHILD-PUGH scoring system, and it can distinguish the good and bad prognostic criteria of the patients. And esophageal varices, anal splenomegaly with blood platelet count suggests clinically important portal hypertension. With these features, we can stage up the hepatocellular carcinoma. And this is the chart for BCLC staging of liver cancer, and it can be classified into stage 0 to A, stage B, stage C, and stage D. And we should remember this, and we should follow this. I have already mentioned that it is dependent on the extent of the tumor, the liver function, performance status, etc. So this is the ESMO clinical practice guideline for hepatocellular carcinoma. And there are different options for early stage, for advanced stage. There are different options of treatment, like surgical option and non-surgical options. And we can see here in case of BCLC 0 to A, the resection or liver transplantation or ablation. These are the options. Definitely in case of early stage hepatocellular carcinoma, the role of radiotherapy is also administered recently. And in case of BCLC B staging, liver transplantation or resection or TACE, these are the options. So I will go through in details in the following slides. So now at first, the management of early and intermediate hepatocellular carcinoma. Before starting the management, we have to know and we should follow that all the patients should discuss in a multidisciplinary tumor board, including the liver and transplant surgeon, before going through the treatment in case of hepatocellular carcinoma. And these are the surgical management like resection or liver transplantation. These are the surgical management. My today's topic of discussion is non-surgical management of hepatocellular carcinoma. So we can classify the non-surgical management of hepatocellular carcinoma into two types, that is the locoregional treatment and the systemic treatment. And here you can see that this is the management of earlier intermediate hepatocellular carcinoma with locoregional treatment, like it can be done by RFA, that is thermal ablation. It can be done by TACE, that is transarterial chemoembolization, or it can be done by radiotherapy like SBRT or SGR brachytherapy, or it can be done with SIRT. So now, this is a paper published in 2021. It's actually a systemic review and meta-analysis, the survival comparison between the RFA and surgical resection for pathological with small hepatocellular carcinoma, and for patient with a small hepatocellular carcinoma. And 19 studies were included in this paper, and around 15,000 patients, and they concluded that their clinical data suggested that surgical resections offer better long-term oncological outcomes than RFA in case of small hepatocellular carcinoma. So come the now the combined modalities of treatment has come, and this is a paper published in 2013 in Journal of Clinical Oncology about the radiofrequency ablation with or without TACE, that is transcatheter arterial chemoembolization, in the treatment of hepatocellular carcinoma. It is a prospective randomized trial, and here we can see that the overall survival and the recurrence-free survival both are better with the combination, that is the TACE RFA combination arm. Both the OS and PFS is better. Now, what is RFA? That is radiofrequency thermal ablation. This is the first line treatment options for very early stage of hepatocellular carcinoma, that is BCLC 0 stage, and RFA is an alternative first line options for early stage hepatocellular carcinoma up to 3 lesions and up to 3 centimeter of lesion. So think one case of early stage inoperable hepatocellular carcinoma, patient with BCLC stage A hepatocellular carcinoma have small, that is less than or equal to 3 centimeter tumor, limited tumor burden, that is less than 3 foci, and normal or moderately compromised liver function, like CHILD-PUGH criteria A or B. Many of these patients are ineligible for primary surgical resection or transplantation due to the age or comorbidities. Curative option includes aggressive local ablation therapies, and RFA is the most commonly used ablation therapy modality and has the most accumulated evidence of its efficacy for treating this hepatocellular carcinoma. However, RFA is not appropriate for lesion adjacent to the large vessel like portal vein or hepatic artery branches or central biliary structures, stomach, bowel, or heart. Also, the efficacy of RFA decreases with the tumor size. In that situation, SBRT does not have these treatment limitations and may be an effective modality of these patients. So come to the points of radiation, role of radiation in case of hepatocellular carcinoma. Before 1990s, whole liver irradiation was the standard of care. But between 19 to 2005, partial liver irradiation has come in front from the Japanese trials and the Michigan trial. And then after 2005 to 2017, and also nowadays, SBRT for liver tumors are the popular and standard of care. So what is the rationale of liver radiotherapy? Initial studies of liver metastasis and primary liver cancer, whole liver radiotherapy was given. There are high incidence of radiotherapy-induced liver disease, that is called RILD. Anicteric hepatomegaly, raised alkaline phosphatase was observed in more than 30 gray of radiation. So the dose of radiation is limited to 30 gray. But liver is a partial organ radiobiologically with functional subuterine arrangements parallelly. parallel function radiobiologically with functional subunits and is parallelly, not serially. So applying this surgical concept, ablation of certain volume of the liver using the radiation, as long as you don't damage the liver normal tissue, it with this rationale liver radiotherapy come. Then came the technologies and came the conformal radiotherapy. Multi-leaf collimators are used to shape the beam to the tumor, and computerized treatment planning system allowed generation of dose volume histogram to show how much liver got how much dose. And the concept of TCP versus NTCP, that is tumor control probability and normal tissue complication probability, will help in this conformal type of radiation. Then stereotaxy, that is the technique borrowed from the intracranial radiosurgery technique to accurately reach the target with respect to an external coordinate system. And now IMRT, VMAT, and helical tomotherapy techniques are used to deliver these sorts of radiotherapy to the liver cancer. But two important issues we should remember. Number one, motion management, and number two, image guidance. I will not go through the details of this because otherwise it will take a long lecture of SBRT in liver cancer with this motion management and image guidance. So hypofractionated, yes, SBRT is a hypofractionated technique. So hypofractionated radiation is high dose per fraction and shorter schedule, and individualized dose prescription adopted based on the liver function volume to be treated with the radiation. So in case of early stage hepatocellular carcinoma, when the candidate is not for transplant, ineligible for RFA or magnetic wave ablation, that is MWA or TACE due to the technical reason, or post RFA MWA TACE recurrence or residual, or medically inoperable early stage cases. In that situation, you can see this is a paper. It's a review article. It was published in 2018 in Technology in Cancer Research and Treatment Journal on restricted body radiotherapy, that is SBRT for hepatocellular carcinoma, current trends and controversies. And in these 11 papers which are included here, you can see that SBRT technique were given in all the papers, all the trials, and you can see the tumor size is more or less around 3 centimeter, except this one. And you can see that the 2-year local control was 64 to 100%. That is really a great. So SBRT can 2 years local control with SBRT is satisfactory. This is initially I have told about the definitive treatment with this SBRT in case of hepatocellular carcinoma. But sometimes before transplantation, sometimes we have to, in case of early stage hepatocellular carcinoma, we have to do bridging or downstaging. So we have to know what is bridging and what is downstaging. At first, downstaging, treatment used to bring the patient whose tumor burden is outside the accepted criteria for transplantation to within the accepted criteria with the help of radiation. This is called downstaging. And what is bridging? Treatment of accepted transplant candidates with this radiotherapy within the Milan criteria while on the waiting list to avoid the dropping of the list. That is, sometimes we have to wait for a long time, maybe 6, 7, 8 months for liver transplantation. In between time, we can give SBRT for bridging purpose before transplantation. And this is a paper. You can see that in most of the papers here, the bridging is done actually, and you can see the waiting time here. And after that, the local control was great. So regarding downstaging and bridging, the summary is 63 to 100% of the patient receiving radiation as bridging are reported to proceed to transplant. Low rates of toxicities, 5 to 10% of grade 3 hepatic toxicities. The complete pathological response was found about 14 to 27%, and the partial pathological response was found 23 to 64%. So it is also a great option of SBRT in case of hepatocellular carcinoma. Now, the intermediate and advanced stage of hepatocellular carcinoma. Here you can see it is a paper published in 2013 in Journal of Clinical Oncology about the sequential phase 1 and phase 2 trial of SBRT for locally advanced hepatocellular carcinoma. The number of patients was 102, and you can see the overall survival was good. At the median overall survival was 17 months with this SBRT. So come to the NCCN guideline. What our NCCN guideline is telling. This is the latest version 2021 version 3. So here we can see in the red box that SBRT is an advanced technique for hyperfractionated external beam radiotherapy with photon that delivers large ablative doses of radiation. There is growing evidence for the usefulness of SBRT in the management of patients with hepatocellular carcinoma, and this SBRT can be considered as an alternative to ablation or embolization technique, or when these therapies have failed or contraindicated. And SBRT typically within 3 to 5 fraction is often used for the patient with 1 to 3 tumors, and SBRT could be considered for larger lesions or more extensive disease if there is sufficient uninvolved liver or liver radiation tolerance can be respected. There should be no extrahepatic disease, or it should be minimal or addressed in a comprehensive management plan. The majority of data on radiation for HCC liver tumors arises from the patient with CHILD-PUGH A liver disease, and safety data are limited for CHILD-PUGH B or poorer liver function. Those with CHILD-PUGH B, the safety measure should be taken. But in case of CHILD-PUGH C, like cirrhosis of the liver, there is no recommendation of SBRT. So in a nutshell, if we want to see the common indications of SBRT, medically inoperable early stage hepatocellular carcinoma, number 1. Number 2, patient planned for transplant as bridging or downstaging. Number 2. Number 3, ineligible for TACE, RFA or tear due to the technical reason like vascular anatomy, coagulopathies or tumor location. In case of post-TACE, RFA, tear or recurrence or residual, we can use this SBRT. And patient selection criteria, definitely CHILD-PUGH A, and in some parts of CHILD-PUGH B, 700 cc normal liver should receive less than 15 gray up to 5 lesion and no extrahepatic disease. Now the management of advanced. Can you hear me?
Mute yourself. Mute.
Okay, so now the management of advanced disease of hepatocellular carcinoma. First recommendation, or first we should remember that chemotherapy is not recommended as a standard of care in case of hepatocellular carcinoma. So we have some options in first line or second line like sorafenib, lenvatinib, regorafenib, cabozantinib, ramucirumab, or some immunotherapies. I am going through some details with this, and this is the NCCN guideline where we can see the different modalities of systemic treatment, how we use in case of advanced stage of hepatocellular carcinoma. So the first paper on sorafenib published in New England Journal of Medicine in 2008 about the sorafenib used in hepatocellular carcinoma. It is a multi-center phase 3 double-blind trial of 600 patients where the patient not received any treatment prior to sorafenib, and the primary endpoint was overall survival, and secondary endpoint was radiological progression and safety. And you can see here with the use of sorafenib, the primary overall survival was good. Yes, in case of progression-free survivals, there was no significant difference, but radiological progression is delayed with the use of sorafenib. Definitely, there must be some side effect like diarrhea, weight loss, and food syndrome, etc., that can be managed. And nowadays, with some other drugs that can be managed easily. Then the lenvatinib versus sorafenib in case of patient with unresectable hepatocellular carcinoma. It is also published in Lancet Oncology in 2018, and here it is also a phase 3 multi-center trial of around 950 patients, and in one arm lenvatinib and another arm sorafenib was used. Primary endpoint was overall survival, and yes, this trial doesn't meeting the criteria. That is, it is a non-inferiority trial, and it meted the criteria that the lenvatinib is not inferior to sorafenib. And regarding progression-free survival, it gives very good outcome. So the lenvatinib was not, they concluded that the lenvatinib was not inferior to sorafenib in overall survival in untreated advanced hepatocellular carcinoma, and the safety and tolerability profiles of lenvatinib were consistent with the previously observed. Then regorafenib, that is the resource trial. It is a randomized phase 3 trial where the advanced hepatocellular carcinoma who tolerated sorafenib and progressed on sorafenib had a CHILD-PUGH A liver function, were enrolled in either regorafenib or placebo, and the primary endpoint was overall survival. And here we can see that with the treatment with regorafenib, the median overall survival was 10.6 months, and with placebo it is 7.8 months. So regorafenib is the only systemic treatment shown to provide survival benefit in hepatocellular carcinoma progressing on sorafenib till 2016. Then it is an additional analysis from phase 3 resource trial that the sequential use of sorafenib followed by regorafenib, and the median survival from the start of sorafenib were 26 months when the regorafenib were used, and 19 months when placebo was used. And regorafenib conferred benefit regardless of the time of progression on prior sorafenib, and regorafenib tolerability was comparable regardless the last sorafenib dose. Then in 2019, Lancet Oncology published the REACH2 trial, that is the ramucirumab trial after sorafenib in second line setting, that is advanced hepatocellular carcinoma. Second line after sorafenib will CHILD-PUGH score A, and performance status is also good, and alpha fetoprotein is more than 400 nanogram per ml. These are randomized to ramucirumab and placebo, and the primary endpoint was overall survival. And here we can see that with the ramucirumab, the primary endpoint, that is the overall survival as well as the progression-free survival, is higher. So REACH2 met its primary endpoint, showing improved overall survival for ramucirumab compared with placebo in patient with hepatocellular carcinoma and alpha fetoprotein concentration more than 400 nanogram per ml, and it is well tolerated and with manageable safety profile. Then the cabozantinib, that is another drug in patient with advanced or progressive hepatocellular carcinoma, and the cabozantinib was used after sorafenib or after 2 line of prior systemic therapy, and among the patient with previously treated advanced hepatocellular carcinoma, treatment with cabozantinib resulted in longer overall survival. We can see 10.2 months overall survival, and progression-free survival was 5.2 months. In comparison to placebo, it is 1.9 months. So it is also an recommendation. Now the some slides on checkpoint inhibitor, and these are the approved immune checkpoint inhibitor in case of hepatocellular carcinoma: nivolumab, pembrolizumab, atezolizumab, CTLA-4 inhibitor, that is ipilimumab. These are the approved ICI. So when do we use PD-1 inhibitors? Like two PD-1 inhibitors, nivolumab and pembrolizumab, and it should be used when it is not a candidate for when the patient is not a candidate for surgery or transplant or local liver treatment, and patient have good liver function and good general health, as well as currently approved only after prior sorafenib use. So it is a CheckMate 459 published in Annals of Oncology in 2019. It is the comparison where the systemic therapy naive patients were randomized to either nivolumab or sorafenib, and the primary endpoint was overall survival. And here we can see that the median overall survival with nivolumab, it is 16.4 months, and with sorafenib it is 14.7 months. Progression-free survival, it is almost similar, 3.7 and 3.8 months, but the response, that is the complete response, 14% and in case of sorafenib it is 5%, and the partial response is 43 and 21. So they concluded that in CheckMate 459 trial, they concluded that though the primary endpoint of overall survival did not achieve statistical significance versus sorafenib, nivolumab showed clinically meaningful improvement in overall survival, overall response rate, and CR rate, that is complete response rate, as first-line treatment of advanced hepatocellular carcinoma. So nivolumab demonstrated a favorable safety profile consistent with previous reports. So it is then recommendation. Then CheckMate 040 trial. It is actually the combination of immune checkpoint inhibitor, that is the combination of nivolumab and ipilimumab, and it is randomized into, it is a 3-arm trial. In first arm, nivolumab 1 mg per kg plus ipilimumab 3 mg per kg 3 weekly, followed by nivolumab 240 mg every 2 weeks. In arm B, nivolumab 3 mg, ipilimumab 1 mg administered 3 weekly, followed by nivolumab 240. And in third arm, nivolumab 3 mg every 2 weekly plus ipilimumab 1 mg every 6 weekly. So in this trial, 1 in 3 patients tumor shrink, half of the patient alive at 2 years, and it works very well in some patients, while in some it doesn't work at all. So the arm A regimen, that is 4 doses of nivolumab 1 mg per kg plus ipilimumab 3 mg per kg every 3 weeks, then nivolumab 240 mg every 2 weeks, received accelerated approval in the US based on the results of this study. This is published in JAMA Oncology actually. So another very promising and popular landmark trial that is published in New England Journal of Medicine in 2020. And after that, the guideline has already changed. That is the IAM-BRAVE 150 studies. It is the combination of atezolizumab and one angiogenic agent, that is the bevacizumab, in unresectable hepatocellular carcinoma. And we can see here that is the survival benefit of atezolizumab bevacizumab combination over sorafenib. And regarding disease progression, we can see that the median progression-free survival is 6.8 months with the combination, and with sorafenib it is 4.3 months. And the quality of life, that is the median time to deterioration of disease, it is long time is achieved by the atezolizumab bevacizumab combination. And regarding toxicity profile, yes, grade 3 and grade 4 events occurred in 56% of the patients who received at least 1 dose of atezolizumab bevacizumab combination, and 55% who received sorafenib. So it is more or less similar. So they concluded in IMBRAVE 150 trial that in the treatment with atezolizumab plus bevacizumab was associated with significantly better overall survival and progression-free survival outcome than sorafenib in patient with advanced unresectable hepatocellular carcinoma not previously treated with systemic therapy. And this combination therapy also resulted in a longer time of deterioration of patient-reported quality of life and functioning than sorafenib. So previously, before 2020, in 2019, the systemic therapy was like this, but after this IMBRAVE trial, 50 trial, the atezolizumab bevacizumab combination is come in the front line. So if you want to sequence the systemic therapy for advanced hepatocellular carcinoma, we can see that is the preferred option is, first line option is atezolizumab bevacizumab combination, followed by second line lenvatinib and sorafenib, and third line cabozantinib or regorafenib or ramucirumab. But if due to the financial constraint or due to some unavailability of drug, if the atezolizumab or bevacizumab is not available or not affordable, then in first line we can use the lenvatinib or sorafenib. In the second line we can use the cabozantinib or regorafenib, even ramucirumab. Even we can use the second line atezolizumab bevacizumab in case of our second line option also. But before ending my presentation, we have to believe that always any sorts of cancer we should manage with the multidisciplinary team approach. Thank you. Thank you so much.
Thank you, Arman. I want to request our today's overseas faculty, Dr. Vinit, to make a quick comment, and then we will go to the discussion. Dr. Vinit.
So I like the schema which he made in the beginning. I think the others, since we have PG students also, that should be the way, we should proceed when we go for a talk. The first slide, of course, if you are in a international meet, it should be your disclosures. Next should be the schema of the talk. how you are going to proceed and how you are going to. And as he has rightly mentioned in the slides, the matter in the slide should be minimum and you should talk more. So you should have only bullets and you should highlight the most important studies which he has done. So I think he has done a good job. Very good, Dr. Chaudhary.
Thank you, sir.
So thank you, Dr. Vineet. So there are some questions in the chat box, but before going to that, we will discuss the question, but I have checked out some few points there, some recapitulation and some discussion. So what I have recapped from the presentation of Arman, because I had the freedom to get the copy earlier, so I went through it. So what I learned, the three-phase CT scan. So if we're asking for a CT scan, we should be, I'm talking about the juniors, that we should mention that we are looking for a three-phase CT scan, not a normal CT scan, because normally they don't do for the three-phase CT scan. So where we need arterial, venous, and portal, three-phase, to see that the hepatic lesion is there, because in sometimes we may miss if all the three phases is not there. And another message that Dr. Arman has given nicely, that MRI is a superior imaging tool than CT scan. And he also mentioned that sometimes some of our colleagues made a mistake of requesting for PET-CT, but PET-CT is not a great tool for imaging of liver lesion. So now I want to ask Dr. Vineet, that at your center, I know you are one of the largest academic center in India. So what is your practice for imaging in such situation for liver lesion?
I agree fully. This is the standard of care is a triple phase scan. There is no doubt about it, because it mirrors the biology of the disease. For that, you have to go back into the biology of the disease, when all of us know that the HCC derives its nutrition from the artery instead of the portal vein. So when that happens, then when you do the triple phase scan, in the initial phase, you have the arterial enhancement, followed by a venous flush out, a washout. So if you get this characteristic picture in the scan films, it is almost diagnostic. In fact, earlier, what used to happen was we used to give a lot of credence to the alpha-fetoprotein levels. But now things have changed. You have a diagnostic triple phase scan. The AFP is used as an adjunct. It is not used primarily. And all of us know that there are certain HCC subtypes, like the hepatocellular or the very poorly differentiated cancers, types of HCC. These ones may not secrete HCC because they are totally de-differentiated. So this works on the biology, how the way the things are. Having said that, now we are proceeding towards a tetraphase scan, in which we include a normal basic scan and we add on to the triple phase. So that increases the sensitivity and specificity also. But for all practical purposes, I think the triple phase scan is the best. And as you rightly said, and as Arman also said, that there is no role for PET-CT in these patients. If you have to do a metastatic workup, you have a CT abdomen, probably do a CT chest to get the picture. Because doing that is not going to change your line of management in any way whatsoever, and you're going to spend money unnecessarily.
Thank you, Dr. Vineet. So this is a great message that PET-CT is not important. Another thing is that alpha-fetoprotein is a great identifying marker, but it's not a mandatory that every HCC patient will have a raised alpha-fetoprotein. So suspecting HCC alpha-fetoprotein normal should not rule out that it is not HCC. We need to really confirm that it is not HCC, because once upon a time we used to believe no raised alpha-fetoprotein is not HCC. It is no more true, as he mentioned clearly. And there is a question in the chat box. So we have discussed that due to the very nature of the disease, PET-CT is not a useful tool. Highly vascular area like this type of area, like kidney, like brain, like bladder, like liver, these are not the great candidate for PET-CT. So to see at the primary lesion or even the metastasis, we should not look for the PET-CT. So going back to my discussion plan that, so as the last slide, Dr. Arman mentioned, that multidisciplinary team improves the outcome of hepatocellular cancer management. I wish we have some hepatologists and surgeon colleagues here, because once upon a time, sorafenib or lenvatinib was a pill, and colleagues used to think that they diagnosis and start giving it and it is over. And sometimes maybe we also don't think for the surgeon. So it is a teamwork. And this is a study published in Annals of Surgery Oncology in 2014. They have shown that the multidisciplinary team really shows a higher survival. So even it is there, we need to talk with everybody together, sitting in the same, under same roof, and discuss and decide about the plan. And TACE is a great thing, but it is not for all HCC patients. It is to be identified who is the candidate for TACE. And TACE combines with chemotherapy sequentially, but not together. RFA is effective for limited size early stage HCC. And in the published meta-analysis in 2021, for early stage shown that surgery offers better outcome than RFA. And he discussed in details about the SBRT as a promising option. So in Bangladesh, we had a limited experience of SBRT in United Hospital. And there we have seen 9 patients of HCC, and our local control experiences were great. I'm experiencing quickly that size is not a challenge for SBRT. This was a patient we treated as the first case, which was a 10-centimeter lesion. We were quite scared of treating him, but luckily the response was really great. And at 2 years, it was like this. And then there was a recurrence. We retreated him, and the patient survived for 4.5 years. So this first patient gave us a big confidence, and we lost him, but he taught us how to treat HCC, and it can give a great result. And there is a great study going on by IAEA. They have compared the TACE and SBRT, and they are now doing the study analysis, data analysis, and hopefully by next year, we will get the study result. It is a global study. Many countries, including India, joined the study, I know. And this will give a clue that whether SBRT can be more popularly used. And there was a question in the chat box about the use of SBRT in cirrhotic liver. So I pulled out this paper published, and they have shown that it is not cirrhosis. It is the CHILD-PUGH status of the patient where we can do SBRT. And SBRT, how we decide the dose and where is how much good liver we are having. How can we save the liver? That is the main secret. And this paper have shown that CHILD-PUGH A with cirrhotic liver, we can treat safely with SBRT. And in cirrhotic liver, if we use particle therapy like proton or carbon, then this may give a better effect with less toxicity. So that could be another wonderful solution for cirrhotic HCC. So now I would like to ask our colleague that in Rajiv Gandhi, I know you have TACE, you have RFA, you have SBRT. What is the, I mean, how you are deciding in your multidisciplinary board that to select the patient for TACE, for RFA and SBRT? What is your common practice?
See, as Dr. Chaudhary has already told in the talk, the basic decision is by the BCLC staging. So whenever you get a patient, there are two aspects. One is the staging part, and the other is the patient parameters. So for patient parameters, you have to assess the tumor burden, you have to assess the performance status, the general condition of patient, and which is most important is you have to see the level of the liver dysfunction which has been caused by the disease. So this is the patient's perspective. Now coming to the Barcelona staging, is divided, as he has rightly told, from 0 to D. So patients who are at 0, we straight away go and resect it. Patients who are in A, depending upon the criteria, I'm sure it is on the net. I will not go into detail. You go for either again resection or sometimes transplantation, whichever the category might be, or RFA. That is left to the discretion of the tumor board. You have a multidisciplinary committee which sits and decides which would be the best. B, again, here is the place where that answers your question. If you have a BCLC B, then you can go for a TACE or you can go for a TARE. We are doing lots of TACE and lots of TARE also, and sometimes we are doing bridging therapy. We give TACE, those patients who are waiting for the transplant, we do that. And there are times when we give TACE followed by sorafenib. So that is BCLC B. BCLC C, here is the place where you give these patients treatment with targeted drugs, immunotherapy drugs. And D is the one which is supportive care. So the patient characteristics and the BCLC staging, although there are a lot of stagings, we decide on that and proceed accordingly.
Thank you, Dr. Talwar. So the message that we want to share with the colleagues that if I have TACE, every patient is not a candidate for TACE. I mean, if I have RFA, every patient should not be the candidate of RFA. So if I am fortunate like you to have everything, then we should decide. If I don't have whatever I have, I should not apply one weapon for every enemy. So we need to really decide on the patient's perspective, disease status, and my resources. Because in our country perspective, we have seen as we don't have all the resources, sometimes whatever we have, say for example, I have seen patient treated by RFA, a big lesion, which is not an ideal recommendation. And TACE, sometimes may not be a judicious, but TACE is done. So this, we need to be very cautious about the guideline. So a supplementary question to Dr. Talwar, that if we have a HCC patient with an active viral hepatitis, either B or C, as we know, these are quite common. So what additional thing we need to do along with the management, or shall we wait for the viral infection to be controlled? I mean, how you handle this type of situation?
See, again, for that, you fall back on the biology of the disease. I'll take a couple of minutes and explain it. If you go to the biology of HCC, there are two basic types. One is the proliferative type and the other one is the non-proliferative type. Proliferative type is the one which is predominantly caused by the hepatitis B virus. And hepatitis B virus is known to be the most virulent type of HCC which you have. So when you have HBV associated HCC, these are the patients who are in poor general condition. These are the patients who have a very aggressive disease. These are the patients who have very immunogenic disease. P53, everything is positive in these. So here is the group where you can do the manipulation with immunotherapy drugs or the targeted drugs, because they are the ones which are going to give you the benefit. The RAS pathway, the RAF pathway, the MET pathways, they are the ones which are active in the proliferative type, which is secondary to hepatitis B. The non-proliferative type are the ones which are akin to the normal hepatocytes. And these are the ones which don't respond to the immunotherapy drugs or the TKIs or the other drugs, because the pathways are very, very limited in this type. And we also know that 30% of the cells are immunogenic, which are in the proliferative type. So having said that, if you have a background of this, if you find a patient who's hepatitis B, then you should aggressively start the antiviral treatment. That is the hepatitis B treatment, whatever drugs we have to give, ritonavir or whatever. There can be a combination also. And then after some time, when you find that the GC, PS, and the LFT profile of the patient have stabilized, when all three are in tandem, that is the time to start the treatment.
Thank you. So now we move to that advanced HCC. So therapeutic option and sequence. So we know that there is a first line now, this atezolizumab and bevacizumab is the first line, and then second line. But the problem is there is no recommendation. The main message is once upon a time, many years back, people used to treat HCC with chemotherapy. But today I think we should come to a consensus that hardly there is any role of any chemotherapy in HCC because we have so many options, wonderful options. So we should forget about chemotherapy probably.
Kamal, I would like to add something. There is a phase 2 study of FOLFOX, which is there. Patients who may not be able to benefit or are intolerant to any one of these, then sometimes probably in second line you can use FOLFOX. In phase 2 trial that has shown about a benefit of about 12 to 17% in these cases who are pre-treated with TKIs or IOs. So probably a little role is there, but then it's a phase 2 study.
So what is Dr. Vineet Talwar was telling that we will be discussing later on also, that sometimes the approval was given on response, not on the outcome. As we know, as he was telling, that 30% of the patient will not be doing great or responding to many drugs. So probably that is the group where they will be not responding on second line. This FOLFOX could be an option in a limited way. But in general, like adriamycin and all these old drugs, I think today it is no more there.
Yeah.
But what is the challenge? Challenge is the sequencing. Sequencing is, we know atezolizumab is the first line of treatment. But after that, where to go? I mean, there are many things, many people are talking. We really don't know what is the great second line. And if we start with sorafenib, well, we know we're going to go to many things. But if it's lenvatinib, so dotted line is the uncertain. The solid line is the certain recommendation. So these are the situation. And if you look at the, see this from SHARP trial, that when sorafenib was first established and then reflect, then came the lenvatinib, then this 2020, this atezolizumab, bevacizumab, and then you can look for these are the three first line, and 2020 is the landmark that has changed everything, that bringing this atezolizumab and bevacizumab to the front line. And then if you look at the second line, that this regorafenib, cabozantinib, and ramucirumab. But if you look at the IO, these two, these are not positive trial. They are actually negative trial. The outcome is not that great, but based on the response that has been approved. So still, I think we have a long way to go. So the question is, what is the ideal sequencing? I know Arman gave a talk on this and he have shown something, but for country like us, we have two situations Arman mentioned. One is no matter, go with atezolizumab and bevacizumab. The next question patient asks, sir, for how many days, how many cycles? Big challenge, we cannot face the answer. Next question is, somebody started, can we switch from there to lenva? Another is, start with sorafenib, very seriously toxic, cannot tolerate. So we start with lenvatinib. So this switch over, and once it fails on lenvatinib, what is your practice, Dr. Vineet Talwar? Because why we are asking you, because all these guidelines are from West. So in our country resource setup, you know that there is a challenge, we don't have any insurance. So how you face this type of challenge? I know you face it every day.
Well, the situation is absolutely the same in India. It is not that it is different. One thing I would like to say that we talk so much about the IM-BRAVE trial. The question which is asked is, in real life studies, how many patients actually are fit for IM-BRAVE? Hardly a handful, just 10% or 15%. Because you have a liver which is not working, you have a situation where you can have a bleeding diathesis, you have a situation where you can have thrombocytopenias, you can have autoimmune phenomena, and on top of that, you have a patient who has a cirrhosis, chronic liver disease, portal hypertension with varices. If the patient has varices, you give the patient bevacizumab, there goes your treatment. And at the end of the situation, as you rightly mentioned, the finances, with a great pomp and show, you start, atezo-bev, and after 3 cycles, the patient says, Doctor, I don't have the money, please do something. So I think the middle of the road path, which you also very nicely portrayed, is we do give all these patients lenvatinib. patients who are really very fit, who have a normal endoscopy, who don't have any bleeding from any site, the coagulation parameters are okay. These are the patients who should be subjected to the IM-BRAVE protocol, that is atezolizumab. And these patients do well. So it is the selection of the patients, not the protocol, which justifies the final decision. So I agree with you. Situation is the same here also.
Thank you, Dr. Vineet. I mean, why I raise this question, I always try to bring this real life scenario, not only the finance. Sometimes this is so tempting, you know, it is exciting that I have a patient, I prescribe atezolizumab and bevacizumab and see the magic.
Yeah.
It is not a magic. The result, if you look at the final result, the survival is not a great magic. Even there are big numbers, but it's not a very big magic. But when this study people make a presentation, the company people comes, they present in such a way that it has made a big, upside down in the world. It is not that. So number one. Number two, I think we should be very cautious about using the combination because atezolizumab has its own toxicity and bevacizumab has this serious toxicity because we know every patient of this hepatocellular carcinoma have a risk of bleeding tendency and it can be a havoc if we give bevacizumab to this. And you see the funny thing, they have compared the toxicity with sorafenib, the most toxic drug we know, to show that it is equal. And it is around 50%, grade 3. So it is not a safe combination. So the noise that was made in front of us, that it is comparable, it is very intelligently they have compared with sorafenib, not with lenvatinib. So these are the things, when they design these things, we need to understand. We are not against the good protocol, but as Dr. Vineet Talwar said, we should be very cautious. And we should also discuss with the patient that the journey length we don't know. So to start with something and then end up that they cannot do. So then we will be discussing that sequencing is again a question. Can we give after this lenva? Or regarding lenvatinib, Dr. Vineet Talwar. So do you start, what is the, gradually increase the dose, you just give the upfront the full dose for the tolerance?
Again, you use your discretion wherever you find that I'll come back to the basics. The tumor burden, point number 1. The performance status and general condition of the patient, point number 2. Point number 3 is the extent of liver dysfunction. Once you have this data, you are reasonably sure and your path is charted out. So if you find mild to moderate, you can start with full dose. If you find that it is quite severe, then probably you do it in a graded fashion. And another thing which is very surprising, when you go through these trials, again, there is a lot of difference between clinical trials and the real world scenario. Go to any one of these trials, you will not find the inclusion criteria of CHILD-PUGH. Please go to it again. All these trials have inclusion criteria of CHILD-PUGH only. And we are giving, patients with CHILD-PUGH left, right, and center because there are hardly any patients which you find in CHILD-PUGH category. So that is the paradox, So there is a lot of difference between clinical trials and what you are doing in practice. So many patients who are CHILD-PUGH B7, B8, CHILD-PUGH-C, we are giving lenvatinib, knowing very well that it is not given in the label. So, your clinical discretion is based on these 3 vital parameters. I'll repeat it again for the sake of the postgraduate students who are there. One is the performance status and general condition of the patient, which is paramount. You have to respect the body. Second is the extent of the liver function dysfunction. How badly the liver has been damaged, how many nodules are there, what is the nodule size, more than 5 or whatever. And third, of course, is the actual tumor burden which is there in these patients. So these 3 things, make a mental checklist whenever you see the patient and automatically the answer will be there in front of you. Minus, of course, the finances. That has to be judged separately.
So, Dr. Vineet, as you rightly said, that whenever there are inclusion criteria, even real world data and the clinical trial doesn't match. Sometimes we find a difference because we see the real world data and clinical trial. With clinical trial, they are nursing is done in such a way, everything is so ideal, which is not possible in the real world. And what you mentioned, very interesting, that all is CHILD-PUGH A, but in our lifetime, hardly we get a CHILD-PUGH A patient. Never. But
Never.
we treat all patients as a candidate for this, which is wrong. So repeatedly I was telling that maybe I have TACE in hand and I get a HCC, I should not think about TACE. I should think, is he a candidate for TACE? I have SBRT, so I am a radiation oncologist. So any patient I see, I start thinking, can I do SBRT? No, it should not be. HCC, then we need to think whether he or she is a candidate for SBRT. So as he was always telling, patient's perspective, disease condition, and remaining liver function, all these things. Thereafter comes the finance. And now we think, is he a rich man? HCC, okay, lagao. Atezolizumab and because that should not be the way of thinking, but unfortunately, that is the way that thought process comes to our mind. We need to stop and think and then decide, because nobody is going to stop us if I give anything to anybody. But end of the day, is it worthy? Is it evidence-based? That is why we mentioned this program, that how I treat my patient with evidence-based medicine, because we have the freedom to give anything, but we should be judicious and justifiable. So I think that was the message that we wanted to share. And now, what are the emerging? You can see that things are happening. They are trying to combine with IO, with AI, and we don't know, maybe things will be coming up in coming days. But what about this sequencing? Lenvatinib first or second, there are some retrospective data, nothing great, but they are more in favor of giving lenvatinib. Second line TKI after post lenvatinib, again regorafenib, sorafenib, they have tried and they have found regorafenib is doing better, but still it is a retrospective data. These are not prospective.
Is cabozantinib available in Bangladesh?
Yes, generic.
So that is again a very good choice.
Yes, second line
cabozantinib
is yes,
is a good choice.
So
ramucirumab, again, the question came, why only patients with AFP more than 400 are given ramucirumab? In fact, when we gave it to all, it was negative. Then they did a subset analysis. They found that there was a trend towards improvement in the PFS, those patients who had AFP over 400. So I think in second line, we should put more credence to cabozantinib and regorafenib than ramucirumab or the IOs. IOs have, as Arman has rightly said, IOs have not shown any survival benefit, but still they've been included in the NCCN guidelines because they have got a response. Now the question is whether the response will be there, the tail of the tail, whether it will be there for long or not, that is what is to be seen. And we jump, to conclusions at 6 months, 12 months, 18 months. So that the last word has not been said yet for them.
So as you mentioned, that IO approval is a negative trial only on the response. And who is the responder, we don't know. So it is like, flying in the, looking for a needle in the sea. So that should be the last resort, as you mentioned. So they said that TKI can be after atezolizumab, all this thing. But you see, they have seen in CHILD-PUGH A. So always they are trying this in a very early stage, not in advanced stage, but hardly we see these patients. So few more ongoing trials are going on. Again, they are trying to make some combination. We are waiting. So if you look at the ASCO guideline, they said that first line, again, atezolizumab or sorafenib or lenvatinib is the first line. These are the strong recommendation. But when they're coming to the second line, you see their recommendation is quite weak. So they said atezolizumab, bevacizumab, after TKI may be offered, after sorafenib, another TKI, as he said, cabozantinib or regorafenib, or atezolizumab, bevacizumab, or ramucirumab. All this combination is possible. As I mentioned, these are all retrospective data. they are not strong candidate. They are not. So where we stand now in 2021, Dr. Vineet Talwar, so after so many discussions, so how we can wrap up? I mean, where we're standing today?
So two things. What do we have today? What are we planning in the clinical trials tomorrow? So what do we have? We have TKIs and we have the iron brave study, GC, PS, LFTs, dysfunction, the tumor burden, everything fine. No bleeding from any side. You go for the atezo-bev. If there is any contraindication to the IOs, because remember, even if you put them on atezo-bev and the patient has any side effects because of immunotherapy, then a protracted steroid treatment has to be given, which has its own side effects. So having said that, if that is not an issue, then of course one prefers lenvatinib over sorafenib because of the tolerance and of the non-inferior study which showed that lenvatinib is superior. Then coming to certain issues, patients who are not able to tolerate sorafenib or lenvatinib, and in this small subset, probably you can give single agent nivolumab as first line treatment. It's a niche group. Coming to the second line, you have regorafenib, you have cabozantinib, then you have the two IOs, that is nivo and pembrolizumab. They can also be given, and ramucirumab only for those niche patients who have more than 400 of alpha-fetoprotein. What we are seeing into the future is we are trying to combine local therapies, that is TACE or radiation, with immunotherapeutic drugs, and we are trying to see how they fare. We are trying to give adjuvant immunotherapy or adjuvant TKIs to patients who are high-risk patients, post-ablation or post-resection. And of course, there is a combination of TKIs and immuno-oncology drugs. They're all in phase 2 trials. So probably I think we'll get more and more intelligent, I'll put it that way, as
Thank you.
the time passes.
So let me look into the questions. Why FDG PET is not used? That is already we discussed, Jannatul Firdaus. We are getting some patient with hepatic SOL with hepatitis B positive. MRI CT scan reveals HCC, but the CT guided FNAC said it is metastatic adenocarcinoma. All relevant liver function is normal. It is asked by Dr. Ranada Prasad that clinically it looks like HCC, but the FNAC is telling metastatic adenocarcinoma. So any comment on this situation, Dr. Vineet?
See, again, the guidelines say that if you have a lesion which is 1 centimeter or more and is showing the classical delineation which is there in a triple phase, you take it as HCC until as proved otherwise. Lesions less than that, or lesions who don't have the characteristic radiological picture, you do the biopsy and you have to support it by IHC, that is immunohistochemistry, in which you have to see the glycipan, you have to see the glutamine synthase, and sometimes you can do AFP also on the block. So these three, if they are positive, then probably you're dealing with hepatocellular carcinoma.
We have one audience, our very senior colleague, Professor Mufazzal. He joined us from hospital. He is affected by COVID.
Oh my
So
God.
hats off to him. He and
God
his family
bless
is
him.
affected.
God bless you.
And he has joined, and he raised a question that to put some light on current position of Lenva plus Nivo in advanced HCC.
That's what I was saying. There are now studies which are ongoing in adjuvant setting also, as well as in the metastatic setting, in which you are combining TKIs with nivolumab. It is not the standard of care, and the results are yet to be known.
TARE, you said that you are practicing TACE and TARE also. Any comment on TARE? With some of our students want to know what is TARE.
So basically, patients who have big portal vein thrombus, in which you cannot, technically do TACE. These are the cases which are subjected to TARE, in which you give the spheres of yttrium. You have a lot of radiopharmaceuticals which you can choose. We use the yttrium 90 spheres, microspheres, and it is like giving a local particulate radiation to that area. But the dividing line in both of them is those patients who have a portal vein thrombus, you should go for TARE. If again finances allow, India and Bangladesh, finance is a big problem. One TARE should be about say 12 lakhs, one session. So as compared to TACE. So thrombus, you can give the option of TARE in these patients.
So thank you. And I know that Rajiv Gandhi is doing, I think, one of the highest number of radiopharmaceuticals. They are quite strong. And in prostate and this liver, you are doing great number of this type of radiopharmaceuticals. So if I want to summarize that there are effective therapies now available for all the stages of HCC, but the question is the availability, cost, and selection of patients. Liver transplant is an attractive option with overall survival, but the challenge is availability of the organ and the technology. IO brought revolution in the management of advanced HCC, but we discussed that one size does not fit all. So we need to be very cautious about selection. Combination of therapies are expected to bring better outcome in future. So this is where I want to stop today. And if any of our audience have any questions, still we are already, I think, more than the time. So before that, let me tell that next week we are going to give stop because it's a National Morning Day. So 15th, we are going to have a program. Subsequent Sunday, we will start our new session because with the end of GI today, and we will start breast cancer session just for our participants. We are going to change our design, not like lectures, will be case-based discussion, and we will be trying to bring out real-life questions that everything we face every day. And we will be talking step-by-step management from patient selection to diagnosis, to surgery, to radiotherapy, to chemotherapy. So we will be trying to touch upon every point, and we will be trying to find out more tools so that audience take active participation. And the attractive thing for the juniors, the prize that have been stopped for many days, we are going to start it again. So with these few words, I want to thank our academic part.
Dr. Kamal, I have
Yes,
just point
please.
to share, please. That is a few days back, a few months back, we met a patient. She's a female patient, 67 years old. She had a lump in liver 2 years back. That is at the end of 2019. Size was 4.4 centimeter, and she underwent FNAC from there. The report was adenoma, and all viral markers were negative. Then she was supposed to go for a follow-up after 3 months, but due to COVID situation, she could not. Then she came again in the month of May, and after CT scan, it was found that her lesion is big enough, that is 8.9 centimeter. All viral markers are negative, liver function is normal, prothrombin time is normal, and there is no cirrhotic change in the liver. Endoscopy is normal, there is no varices. At this stage, what may be a good treatment for her? Because size is, by this time, it is 8.9 centimeter, and it is biopsy proved, and it was well differentiated hepatocellular carcinoma. So it is a localized cancer which was initially proved as adenoma. Now the report is hepatocellular carcinoma after biopsy and also immunohistochemistry, and it is well differentiated.
What is the location?
Location segment 7 and 6.
Yes, Dr. Vinit Talwar. 6 and 7. Now is almost 8 centimeter, gradually increasing. Liver function normal, and diagnosed HCC, single lesion.
See, again, as I told you, the patient characteristics, BCLC classification. Wherever it comes, you do the appropriate treatment.
Her performance status is 0. She is ambulant. There is no clinical problem. Only comorbidity is diabetic. So as per BCLC criteria, I see for her it is only we can give TKI or we can also first line treatment epidoli and also bevacizumab. But what we did here, that is, she underwent tests. She underwent tests. In our center, a few patients, though size is 8 or 9 centimeter, test is done. And we are following those patients, result is not bad. Though ideally it is 5 centimeter, but we are doing here 7 to 8 centimeter lesions also test. But for this case, she is not cirrhotic and viral negative case, F is only 2.6 probably. So is it a good option for test for her or any other treatment when she'll be coming next time?
What was shown on the triple phase?
Oh, I cannot tell people at this moment because the reports.
Because that would be the sheet anchor in diagnosis.
But after triple phase, radiologist has told that it is no doubt hepatocellular carcinoma.
So
I think
triple phase was done.
Yes, it was done.
So triple phase was saying that this is HCC.
Yes.
So that brings us to another dimension. Generally, whenever we say HCC, we immediately jump to hepatitis B, hepatitis C, probably alcohol, and then we call it a full stop. Nowadays, I don't know, Dr. Kamal might be knowing, in India, I don't know what is in Bangladesh, we are having a surge of NAFLD, that is non-alcoholic fatty liver disease. And if you see the alcoholic liver disease, which causes cirrhosis and HCC, that is going down further and further. The fatty liver associated chronic liver disease, which leads to HCC, that is climbing up and up. We have it about 15 to 20%, which was just 3 to 5% earlier. So this is a patient who has a big mass. This is a patient who's not non-secretor. AFP is not secreted. Maybe the subtypes like hepatolamellar type, in which you don't have a high AFP. So I think best would be in this case would be, if it is still a liver localized disease and if TACE is possible, you follow it up as TACE followed by a TKI or a TACE followed up with a atezo-bev, whichever the situation might be, because only a local treatment may not benefit and the patient might have residual disease left after a local standpoint treatment. So my choice would be, you do a local treatment and then you follow it up with a systemic treatment as a kind of a pseudo-adjuvant situation.
So Dr. Vinit, I totally agree, but I think that in this patient, SBRT could be a better option.
Yes,
than TACE,
that I want to tell.
No, that is what I said, local treatment.
Local treatment, yes,
can be TACE, can be TARE, can be SBRT, whichever. See, then again, that comes the last slide, which Arman had shown. You guys have to sit together in a multidisciplinary setup and decide according to the patient. It has to be individualized. But the broad decision would be local followed by a systemic treatment.
Yeah, Dr. Kudrat, the challenge here is if the patient had a raised alpha-fetoprotein, after doing a local treatment, we could wait to bring it up. As it is non-secretory, so as Dr. Vinit said, after the local treatment, we need to go for a systemic because we don't have any indicator other than the radiological progression to monitor that it is, because the patient that I treated, it was an alpha-fetoprotein secretor. So when I gave SBRT, then it was shrinking and the alpha-fetoprotein was going down. So I was just keeping the watch of the patient. And when it started again, then we started giving him sorafenib at that time. I'm talking about 7 years back. So what happened that This is how we could monitor this. Non-secretary, I totally agree with Dr. Vineet Talwar, but why I talk about SBRT? Because we know the RFA and TACE, there is a limitation. They said the good thing is if it is something, 5 centimeter, but the lesion is around 8 plus. In SBRT, the good thing is we can do it 10, even 15 centimeter. Only thing is whether we can save the remaining liver. That is the main option. So that's why it is becoming more popular. So SBRT could be an option, but whatever is done, I think fine. But I suggest that we should continue systemic, because non-secretary, we cannot assess unless, because initially there will be response and shrinkage, but whether the activity is there or it is restarting, it is very difficult to assess unless there is a liver damage or again expansion of a new focus. So probably that is the reason. Yes.
Okay. After 3 months, she will be coming for follow-up. If I see that her lesion is a bit reduced, maybe 5 centimeter or 6 centimeter, can she go for again TACE or she may go for SBRT? Which
Repeat
one
TACE
will
is
be
okay.
better?
Repeat TACE is multiple time TACE is allowed, but there need to be
Yeah, that can
interval
be done.
time. Yes.
Yeah.
Dr. Elahi, what
Yes.
did prevent this patient to undergo surgical resection? Was it in close proximity to a great vessel, a bile duct,
Sir,
or something like that?
The position,
Sir.
location.
Position and sir, she was seen by a hepatic surgeon.
That was inoperable.
It was inoperable case, and also he planned for inoculation, which is not a very standard
No,
treatment.
no.
So we stopped it.
That's the reason. Okay, I got it.
So I think if next time onward we can get these scans also in the meeting, you can get a fair idea, and immediately you can tell the position. But the broad thing would be local followed by a systemic modality.
Thank you very much. Dr.
Thank you
Bennett.
very much. So it was a great day. I mean, we had so many discussion, and today we had 40 plus participation, which was great. I am so happy to see that our colleagues are taking interest in hepatocellular carcinoma, because it was a non-rewarding topics once upon a time. Now we have some great drugs and great options, and it was a great discussion. And thanks to Arman and thanks to Dr. Vineet Talwar. So, and also thanks to all the participants now, and also to our academic partner. I request all the participants to share that after 1 week, we are going to start a new session on breast cancer. And there we are going to discuss in a different format. It will be case-based discussion, and we will try to bring all the questions that you face every day in your practice life and how we can solve it. That will be our steps. And we agree that last 1.5 years, we were doing more systemic therapy-based biased discussion. But now we will be trying to make a balance between the local and systemic, that is radiotherapy, surgery, and systemic therapy all together. And we will be having our faculties on respective departments, and hopefully it will be helpful and enjoyable. So I want to ask our president, Aisa, to conclude the session, sir.
Thank you, Kamal. We had a very great session today. Very interesting, very useful. Evaluation of Arman has played the thing very nicely, covered almost all the aspects of non-surgical management of liver cancer. Also, very thorough enlightening us. Latest developments and how we can manage. Okay, from next time we are, Kamal has said, we're going a different way. This time, I hope participants will take part. Allow the participants to give their opinion, not just listen and go home. Thank you. Thank you very much again, once again, and also our academic partners. Over to you, Kamal.
Thank you, sir. So I want to thank our academic partner, Acuvida. Thanks to Dr. Vineet Talwar for successive 3 holiday sacrifice. And
My pleasure.
don't worry, we will be calling you very soon. Not in breast cancer, but in other sessions.
Yeah,
And
definitely.
not you, but some of your colleagues will be busy with us. Thanks to Rajiv Gandhi Cancer Institute for your continuous support. Congratulations, Arman, for such a wonderful presentation. And thanks to all, special thanks to Professor Mufazzal. I mean, for joining from the hospital. We all are praying for you, inshallah. Very soon you will be recovered and you will be joining us with a good health not from the hospital, but from your clinic or from your home. And we hope that this journey will continue, and the endeavor of Oncology Club of learning from each other, giving the best to our patient will continue. And we are so happy to see that our juniors and even our seniors are taking equal interest in this type of discussion. And this shows that we all are learning from each other. Our cancer patient deserve the best, and let us try all together to give him the best. Thank you very much. Goodbye, everyone.
Thank you, everybody, for praying for me as well as my family members. We are slowly but steadily improving, inshallah.
Inshallah, it will be fine. So
Thank you,
goodbye,
sir.
Dr. Vinit Talwar.
Bye, Kamal. Take care, please.
Take
Thank
care.
you so much.